you very much, Dave. And thank you everyone for a great round of presentations there. So I'd like to ask Dr. Schuster, Dr. Beck-Jordan, Katie, Beth, and Dave to come live now for the panel discussion with Dr. Andrew Watson. Thank you.
Thank you all very much, and we do appreciate your time here on Saturday. And we have a couple questions. I just want to highlight also some of the questions we're getting from the audience. And Dr. Zuriket had a question, and we will connect you with Terry Lewis about that. And we appreciate the feedback from St. Patrick's Mental Health Services and that engagement as well. And actually, Ellen, we had a question from the audience that said there's so much discussion about the impact of COVID on health inequity within societies. Can you comment on whether we believe the digital divide will worsen or improve health inequities in the virtual care world?
Thank you, Andrew. I think we have to commit to ensuring that it doesn't worsen divides and in fact ameliorates them. We know that the nature of the digital divide has changed significantly, and rather than being about who does or doesn't have access to mobile devices, it's more often now about who does or doesn't have access to broadband internet or resources to pay for broadband internet. So we're looking very closely at that. We know that that's a requirement for all of the benefits of digital health and telehealth to meet their full potential in improving access to care, and in doing so play a major role in reducing health disparities and improving health equity. So I think we have to be intentional about that, and it's something that I know we're paying close attention to, understanding where broadband deserts exist geographically, figuring out how to work with national carriers to ensure broadband access to our members, directly subsidizing the costs of broadband access through federal, state, and local programs. So I don't think it's a given that if we don't intentionally address that, things will work in favor of improving health equity. So we're looking very closely at that to make sure that we can, in fact, leverage these tools to reduce health disparities, which they clearly have potential to do.
Yeah, thank you, Ellen. And with the term broadband desert, it's really a new term for me, but also fairly applicable when you look at what's happening in the western part of the United States right now. It's quite scary. And I actually want to go out of order a bit and go over to Katie, because she talked a lot about the age of patients that are using the portal with My UPMC. And I think it's important just to pull that thread through just a little bit more. And also, Katie, we love to hear some of your input about just self-entered data and wearables, because these days on Amazon, you can buy anything under the sun, and there's a lot of it in healthcare. And thank you.
Yeah, absolutely. I mean, I think the age piece is very, very interesting. We expected, anecdotally, right, you expect it to be the younger demographic that engages. You expect it to be the younger demographic that's more satisfied or more comfortable with these new methods. And I think, when we really dug in and looked at the data, it was much more widespread, and it was much more even, right? I think the places where we have gaps are, I think, what Ellen talked about, right? Where we have a group that can't use broadband or doesn't have reliable access to broadband or isn't familiar with those kind of tools. They're not familiar with downloading apps at all. And that's really where the gap is. And that doesn't fit on age. That fits on location, that geographic distribution, and it fits on economic disparities more than it does on age. And so that's really what we're starting to look at now, and making sure that we provide access to who needs it, as opposed to assuming it's our users that are over 60 that are going to have a problem. So it's not the tech savviness necessarily that we would have seen 5 or 8 years ago. It's really a different set of problems. So I think that's an interesting one. And then if we sort of pivot to patient-entered data, I think Dr. Sinhan's conversation, I think, is an appropriate one for this, right? I think that Apple Health Kit, they're pushing patients to enter their own data, to be able to push that data to health systems. You can connect it to your EMR. But the question is always, like, for what, right? So connecting the technical pieces is the easy part, but, like, what are we going to do with that, right? Nobody wants to see my step data. It's not interesting, right? There's no reason to look at how many steps I took yesterday. Maybe it's interesting to me, but my doctor's not going to look at that. So what's sort of the partnership we're creating with that clinical care team to say, hey, maybe after surgery, we really care about your step data to make sure you're getting around enough. Maybe we really care during pregnancy to make sure you're getting the right level of activity. And maybe with certain patients, we want to see how that trends over time. But until we figure out exactly what the baseline conditions are, and what the goal states are, and what the intervention points are between the patient and the clinician, the data is sort of a nice to have, right? We'd almost rather not have it because we don't, we're not going to do anything with it, right? So I think there's an opportunity there to say, what use cases is this valuable, and then how do we make information and goals and value out of that? And that's, I think, a trending problem, a data collection problem, an AI problem, honestly, at some point, to be able to say, for these set of conditions, oh man, this is really important. The trend we saw means we need to go intervene on a Saturday morning to go do this, right? And if we don't have that, pushing me your step data or pushing me your blood pressure data, we can have it, we can store it, but that's not going to help, the clinicians or the patients. So.
Yeah, I completely agree about the AI, and it's such an important point, especially in the monitoring world. I think it's a powerful part of the future. And also, I hope that the health plan doesn't see my step data during this meeting because it's about 4. So you're right. Who wants to see our step data? And James, with that, I mean, as the chief medical officer of the health plan and a payer that oversees millions of members, and you're looking at this from a population health perspective with Ellen, what do you see the greatest value in this moving forward with the virtual care or tele? I'm just curious to get your perspective there.
Sure. Thanks, Andrew. I think there's several ways in which telehealth brings value to our members. So I thought it's probably worth just giving a few brief examples. So our goals as a health plan there are at least a few key ones. So the first is to pay for care that we all see as medically necessary as efficiently as possible. Emergency cardiac care, things like treatment of opioid addiction, supports of pregnant women are all examples. And you heard throughout the conference this morning ways in which telehealth can help support initiatives like that. The second is to really try to make care as accessible to members as we can. A significant part of it, accessibility, is convenience. So the traditional NCQA framework for thinking about accessibility, for example, is to have a certain number of providers within 30 minutes or 30 miles of a member. But that care is not necessarily accessible to a mother who can't find childcare, or someone who might only live 5 miles from a provider, but doesn't own a car and can't get there on a bus route. So telehealth can definitely help us with accessibility issues. And then the third, and probably the most important one, is our goal is to really try to empower members to better manage their lives and their care themselves. Yeah. A 5 or 10 minute occasional visit with a provider doesn't usually lead to behavior change for any of us. But easy accessibility to digital tools with concurrent coaching or other supports of the type that you heard about this morning can really support members' ability to accomplish goals like better managing their weight, addressing dependencies like nicotine, and engaging with peers who are wrestling with similar issues. So I really think telehealth can help us with all of these challenges and all these efforts to help our population health. Kind of implies we're managing the health of the population, and really the right frame is we're trying to empower our members to manage their health better themselves. So telehealth, I think, really has provides lots of opportunities and advantages as we move forward in that framework.
That's a great perspective, James, and thank you very much. And Dave, transitioning over to you, we did get a question from the audience about do you partner with individual infectious disease physicians out of state, which I want to make sure that you're aware of. And also just would love to hear about some of the challenging questions you get from hospital executives when you're working with them, because it's so impressive the work that you do about antimicrobial stewardship and supporting us as physicians when we're making these very difficult decisions, especially in the era of drug resistance. We also see in COVID that I think a fair amount of the care has been delayed, and the complexity I see in my surgical clinics is much greater right now than it was a year and a half ago. But I'd love to get your thoughts on some of the questions that you're getting during your engagement cycle, and also whether or not you work out of state. And thank you for your time.
Yeah, thank you, Andrew. And to answer the first question, we do work out of state. We're in 10 states now and growing, and we would love to partner with other physicians. So if someone wants to reach out, please do. And as far as the questions, it's interesting. We get questions across the different services, and I would say, most times we get quickly beyond they know they need a service. They know they don't have the ID specialty. And what we really get to on the services side is how can we improve quality initiatives. How can we have a longer term impact than just patient care, but educating the clinicians at that facility, making, kind of permanent change. It's, a lot of times it's change management that we're bringing to the table as much as patient care. And on the Illum front, with the antimicrobial, it's really similar. I mean, today, I think a lot of, I think people I guess they didn't realize, or because of the pandemic and the emergency there, that the new rules and regulations were put into place for antimicrobial. So we get a lot of questions about complying with the new rules and regs. And again, I think there it's one of the things people poke at the most is, how long is the implementation? How hard is this going to be on my IT folks? That's something I think all hospitals are dealing with today. There's a backlog of to-dos. And so it's a priority issue. And, fortunately, we're a very low touch implementation. Most of that data work, we get data feeds, and that data work is on our front, not the IT people at the hospitals. And then we always get, and I'm sure anybody on the panel who provides services, we get the ROI question. And we understand that we need to have great patient care. We have to make great clinical improvement, but we also have to drive results. And fortunately, we can provide both of those. So.
That's great. It's interesting hearing what you say about quality as well. Just like Deanna was saying in her comments as well, it's so important how you distribute the education and the quality using telemedicine. And Beth, it's great to see you here. Thank you again for joining. And it's always so impressive the work that you and Hai have done. And I'd love to hear just your thoughts. And this has been so successful with the postpartum hypertension. And right now, it's do you think that patients at some point or members will actually want to buy these services for long term? I mean, if I had high blood pressure and I could pay $30 a month and be monitored for the rest of my life, these sort of consumer purchase services really may come to fruition because it ties us to our own providers at UPMC. I'd be curious to hear your perspective there. That's not all about money, but I mean, it's this kind of consumerism of medicine right now.
Right. Thank you for having us, Andrew. I appreciate the opportunity to talk about it. I'm not positive about the fact that if they would pay for it. I think we have seen with this population, especially with our postpartum moms, we struggled to get, the idea of the blood pressure cuff. Like we give them a blood pressure cuff because we weren't sure that if we didn't give that to them, they would still participate in the program. So I'm not sure if we would find that they stayed on. I think we are finding the women that are realizing their disease, that it's not something that's cured with pregnancy or at the end of pregnancy. And we are trying to really keep them transitioned for a longer period of time and put them into programs, a bridging program where they can stay with us for up to a year or so to transition to care coordination. They are participating, and perhaps eventually that would be something that people would find important enough to pay for. For now, I think it's just a matter of making sure we are providing so much of that education to get them enrolled and understanding the importance of it and the connectivity to it. They really seem to like the connectivity, the fact that it comes to their phone, it reminds them to take their blood pressures. They can then connect back and have someone actually monitoring it, like Katie had said too, like just making sure that it's not just going into digital space where no one's watching it. Someone is looking at it, and then a provider, an actual doctor, is going to be called for it and tell them what to do with it and change their medications and help educate some of that through the nursing team. That's all been very important. And I think as that continues to other programs, potentially, I think that's where we'll find the benefit that people might really start to buy into. This is a consumer driven product that they could purchase.
No, thank you. And I don't want people to think it's all about money, but it's an interesting part of telemedicine. What's going to happen in the future? You buy a television and buy clinical care at the same time, or go to Costco and buy all those protein bars and buy telemedicine too. Who knows? And you're really proving it, Beth, because either your car is your background picture, it shows you how mobile we all are these days. But it's always impressive the work that you've done at McGee, and it's really transformative for women's health, and it's so impressive. And thank you to all the panel members for your time on a Saturday. It's warm and sunny here in Pittsburgh, and a bright sunny day, our usual. But appreciate your time. And Michael, we'll send it back to you. Have a nice day.
Thank you.
Thank you, Dr. Watson and team. That was a great discussion. This brings us into our next keynote presentation. So In this presentation, we'll describe how UPMC internationally sees virtual health and telemedicine as playing a role in the current operations and future operations of our international expansion. Our presentation will be by Dr. Matthew Herenstein. He's the co-course coordinator on this course, and he is the Senior Vice President, Associate Chief Medical Officer, and Chief Operating Officer of UPMC International. So Matt will be describing our perspective on UPMC's international growth and how we see virtual healthcare and telemedicine playing a role in that. After Matt's presentation, we'll have a roundtable discussion with our international executive leadership to describe from today what we see as areas of opportunity in this space specific to each country. So looking forward to your presentation. Thanks, Matt.